and Shreya, Shruti, Bharti, Imtinan, Sara, Mahwish, everyone, Nazia, Sadia. So I welcome all of you. Inam, how are you doing? Faiza, brilliant. Brilliant, brilliant. So I think we are going to have a very good discussion. So I really expect all of you to participate in the discussion because, it's not like, I'm going to just talk and talk and talk. Okay. So we are going to have kind of, small questions as well. And, in between, I will try to highlight the important exam aspects as well. Okay. So before that, if you guys have any question regarding preparation or anything, you guys can ask, or we will just directly start our session because I am really excited to talk about these two important TOG articles today because in recent exams, even in July and the September, these two TOG articles have been included in those exams, in fact. Okay. So we are going to talk, about the most important exam aspect of, these talks, and in upcoming week, the days, in fact, in this week, because we are celebrating a kind of talk week. So hopefully you guys will be having, two more sessions with our two brilliant mentors, okay, along. So I think it's going to be day after tomorrow, and then again, it's going to be on alternate days. Yeah. So today is the first, the day of this talk week. So I hope this is going to help you a bit in your exam preparation. Okay. So I am reachable. So if anybody has any kind of issue regarding preparation or anything, you guys are more than welcome to reach out to me for anything, okay? For any help, any preparation guide or anything. All right. Walaikum assalam, Sana. Walaikum assalam. I believe this is Sana Zahir. So I'm so lucky and overwhelmed to see you, Sana. So good to see you. Oh my God. So good to see you back. So good to see you back. Yeah, me too. Me too. Ask me, I'm so happy. And in fact, I'm so lucky. And it's been 5 years, exact 5 years we are together. Yeah. Very good. Very good. So let's get started with our business because we have to talk a lot today. And obviously, we have to discuss important aspects of exam as well. Hello, Nazia. Hello. Walaikum assalam. Walaikum assalam. I'm familiar with your name as well. These are perks of being, the admin of Facebook group, obviously. So, yes, we tend to know, many people around, but obviously, it's hard to interact with each and everyone. But yes. Hi, good evening, Manikam. Congratulations, first of all, and all the best for your next part. Okay. So good to see you.
Thank you, ma'am.
I hope you are doing well. So if you need any kind of help in part 3, okay, you can always ask me. Okay, send your templates and audios for feedback even. I don't mind. Okay.
Thank you, ma'am.
Okay, my dear. That's good. Okay.
Hello.
So, hi, Dr. Hassan. hello, sir. How are you? So I think Sir Hassan was here, so he will join again. I'm sure. Okay, so let's get started with our 2021 TOG articles. Okay, so I will share the complete TOG articles list and the important TOG articles in this week. Okay, in part 2 guide group. So guys, be there and just be vigilant with my post. Okay. So, I will try to highlight the important, the TOG articles, what need to be covered from 2021, 2020, and even, before that. Because, in the curriculum, obviously, you have to cover 3 to 5 years TOG articles. And yes, the topics which haven't been covered by any guideline, be it, the Royal College guideline or the NICE guideline. All right. So I will be telling you, time to time that which thing is important and how to cover and how to make your own notes as well. All right. So let's first talk about this very advanced maternal age. This is the TOG article 2021. Okay. So recently this has been a highlight in the many countries, because they say that the women who become mother for the first time, okay, they are kind of the advanced in their age. But who is going to tell me what do you mean by very advanced maternal age? Anyone? Hmm? Who's going to give me the definition? Kindly open your mic and just give me the definition. Mm-hmm.
It's women who are aged above 45. They are categorized as very advanced maternal age.
Yes, very good. Yes, because the medical literature uses the term very advanced maternal age to refer to women who are aged 45 years or more at the time of delivery. Okay, this is very important that we have to give the complete definition, because although if we just take this the word as a just the English word, so very advanced maternal age doesn't bother us much. But if we just think of that what exactly they mean, so they mean to say is that the women who are aged 45 years or more at the time of delivery, so they are going to be termed as very advanced maternal age. So obviously, if we just talk about as a medical doctor, the medical specialist, that what exactly are the consequences of a mother who become the who is in the advanced age, and now we are talking about very advanced maternal age. So what is the difference between these two? Okay, so once you just feel this difference, that okay, this can happen and this cannot happen, so yes, then your concepts can be very clear. But this part is very much important, that you should understand that the women of 45 years or more at the time of their delivery, they are termed as very advanced maternal age. All right, so very advanced maternal age for the woman who is going to become first time mom. So obviously, what exactly what are going to be the what you can say the treatment modalities for such women. So many women who become mom for the very first time at the 45 years or more, so obviously they are going to conceive with the help of the ART, because the natural chances of conception are going to be low in those women, isn't it? So they say that spontaneous conception in women with very advanced maternal age is rare, but more common in Paris women. Yes, that happens, and that we do see in our countries as well, in our hospitals as well. Yeah. So multiparous, yes, they can become, the very advanced maternal, the very advanced in their age, but yes, they do deliver because they are either multipara or whatever. But yes, spontaneous conception in the woman in very advanced maternal age group is quite rare, first of all. So they say that the conception using autologous embryos is also rare. The live birth rate is quite less, 2.9%. So that is going to be 3% altogether. Okay. So they say in a cycle for women age 45 years, for women age 46 years and older, 2.9% in a cycle for the woman age 45 years. This is for the woman who is going to be delivered at the age of 45 years. So the chances of live birth is only 3%. But for the woman who is 46 years and more, the live birth rate is, uh, more low. So it can be even 0% as well. So we can see that, even with the help of the ART, the chances of having live birth is quite low. Okay, so it is decreasing by even, the 1 year. 45 years, it's just 3%, and by 46 years or more, it's going to be nearly zero. So artificial reproductive technique is associated with in an increased risk of OHSS, isn't it? We are all aware of it. Then miscarriage, ectopic pregnancy, pregnancy-induced hypertension, preeclampsia, VTE, genetic and chromosomal disorders, structural abnormalities, FGR, stillbirth, and preterm labor. All right. So it's not always that the advanced maternal age is going to be associated with all these issues, but yes, ART is going to the supplement or is going to increase these issues. All right. So in this talk, in upcoming slides, we are going to study about all these things in comparison with the spontaneous birth and in comparison with the ART as well. And these are very much important exam aspects. So these risks also increase with maternal age and multiple pregnancies. So preeclampsia. So this is a very important, the example for every pregnant woman there is. Okay, so pregnancy induced hypertension complicated by the preeclampsia or the gestation, or the chronic hypertension complicated by preeclampsia or preeclampsia itself. It complicates almost 1.1% of natural conception and 12.6% of oocyte donation conception in women with very advanced maternal age. And I believe this can be a single best answer. This can be the component of the EMQ spectrum as well. All right. So clear everyone up till now? Because this is going to be a very important thing to cover. All right. Okay, so this is a summary of the risk from the current evidence for the woman of very advanced maternal age, comparing conception with assisted reproductive technique and spontaneous conception. And I will, remove this slide in upcoming slide, and I will ask all these percentages from all of you one by one. Okay, so I think is there Sana is there, Lena is there, who said, and I'm looking for Ahmed, I'm looking for few more people who said that they are going to actively participate. So it doesn't matter, okay? So anyone who can answer me, so that is going to be very good, okay? So let's take disease one by one. So if it is maternal preeclampsia, so in the normal pregnancy, it is just like 1%, okay? Means spontaneous conception. But if it is with ART and the oocyte donation, mind it, they are talking about oocyte donation as well, because the chances of spontaneous conception is quite low in this category. So yes, there can be chances of oocyte donation as well. So maternal preeclampsia is 12.6, and this has been, the exam question back in 2016 and even in 2018. But at that time, when I was studying for MRCOG part 2, so we used to struggle, to find out the cause. So we used to go through so many, the things, literature here and there. And yes, we didn't have this TOG article at that time. So I think this is a very good TOG article to just, memorize things in an effective way. So remember, 12.6 is maternal preeclampsia and delivery before 36 weeks of gestation. This makes what? This makes preterm labor, isn't it? So the pregnancy conceived spontaneously in this age group is going to be 9.3%. But with ART and ovum donation, this is going to be even 20. I mean, you can say, even 3 times, the more, 2 times more than that. So this is going to be 23.3%. So the risk of baby being born with low birth weight of, less than 2.5 kilogram. So in the spontaneous conception, it is only 7.4%, but in the ART group, it is 22.1%. Okay. Okay, so clear everyone? So please, memorize these percentages, and by the end of our session, I'm going to ask all these questions from all of you as well. Okay? Okay, so now this is very much important to talk about the early pregnancy complications with very advanced maternal age. Okay, so now the woman has conceived through ovum donation or ART, and now she has become pregnant. So in pregnancy, what exactly we can expect out of such woman? Okay, so let's take all these complications one by one. So yes, there can be miscarriage, isn't it? So we can assume that miscarriages can be high, but how high? The overall risk of miscarriage is 53%. So who is going to tell me that, apart from this very advanced maternal age, what is the risk of sporadic miscarriage in every pregnancy there is? How much do we think that there can be, the chances of having, the miscarriage? Anyone? Nazia, Rabia, Saleha, Sumbul, Suraya, anyone? What are the chances of, the spontaneous miscarriage? 11%. Any other guess?
11%.
Okay. Any other guess? Lena? Tumbul?
I guess it's 15.
Guess. So I think this is going to be another.
As far as I remember.
90%. Manikam, isn't it too much? You are 90%, Ibrahim. Okay. Chances of spontaneous miscarriage for every, the pregnancy, is it 90%? Okay, now this is your homework. No, I'm not asking about 45 years. I'm just asking about, the any pregnancy, because then we have to compare with this. Okay, then we have to compare with this. Yes, very good. Yes, 10 to 20%. Okay, very good. Yes, 20%, you can say. So if you just take, the sporadic miscarriage, that is 20%. So what will happen in this very advanced maternal age group? So this is going to be, the even more than that, 53%. Okay, so the overall risk of miscarriage in this age group, very advanced maternal age, is 53%. Rates of miscarriage beyond the first trimester are also increased. Okay, like we have said earlier that there can be chances of having preterm labor as well. Okay, before 36 weeks, and then it can be anything. Okay, then what is going to be the second, the most important thing, most important pregnancy complication? So it's going to be ectopic pregnancy. Okay, so what is the incidence of ectopic pregnancy across UK? Anyone? So this is going to be a kind of brainstorming, isn't it? How much is the chances of ectopic pregnancy for any pregnancy there is? Let me check. 11%. 11%. Is it 11 or 11 per thousand? Yes. That's very good. That's very good. It's not 11. Okay. Now let me tell you one thing. The ectopic pregnancy. It is. Hi Pradnya. Good to see you. It is 11 per thousand. It is 11 per thousand. Okay, 11 per ectopic pregnancy. Okay, that is the the rate of ectopic pregnancy across the UK. But there is another thing. What NICE guidelines says that almost 20% of the women who are seeing the early pregnancy assessment unit, those are 20%. Okay, so that is very important because the candidates do tend to mix these two things. Okay, these two are very much different. Okay, 11 per thousand, well done Maliha. And yes, the 20% will see the early pregnancy assessment unit according to NICE guideline. All right, so let's talk about this ectopic pregnancy in very advanced maternal age group. So it's going to be 3 times the overall risk of ectopic pregnancy. So you can just imagine that how much it is going to be, 3 times more than the normal usual risk. So yes, 6.9% risk of ectopic pregnancy in women aged 44 years or even older. So the chances of the third complication, what we do see, is the multiple pregnancy. So in 2018, because this is a recent TOG article, so yes, they have taken the recent data across the the UK. So they said that the women of very advanced maternal age in the UK had a multiple pregnancy rate of 79.3 per thousand, compared with 15.4 per thousand in all women. So this is even quite high, isn't it? So we can just imagine that with the singleton pregnancy, if a very advanced maternal mama is having, all those complications, so with multiple pregnancy, how many and how much, her pregnancy is going to be complicated, isn't it? So yes, remember miscarriage, remember ectopic pregnancy and multiple pregnancy as well. So yes, now because we have said that there are going to be the potential complications. So if we talk about the complications, so as a whole we do call them as morbidity, or if there is any element of mortality as well. So yes, very advanced maternal age is going to be associated with mortality and the morbidity in multiple pregnancies as well. So let's talk about
this. Ma'am, I have a question. Ma'am, this increased risk of multiple pregnancies due to the due to
ART?
spontaneous
ART.
Oh,
ART.
okay.
ART. Okay.
Oh,
yes. Okay. So yes, so let's talk about that, how we are going to deal with this multiple pregnancies and its complication, because I believe that this can be an important topic in this exam. Okay, so condition, if we just talk about the condition, which is the delivery before 37 weeks of gestation. So risk in twins is going to be 56 to 65%. But risk in singleton, it's going to be 8 to 14%, isn't it? So what you will do in, what are going to be the recommendations? Ensure that the women are being cared for in the specialist multiples clinic with a neonatologist intensive care unit that can provide the appropriate level of care for babies born prematurely. Yes, done deal. So it means the patient is going to be taken care of in the consultant-led unit and in the center where advanced NICU facilities are available. Because yes, there are going to be high chances of this woman to deliver before term. And we do say that term is from 37 to 42 weeks. Anything less than 37 weeks is going to be considered as preterm birth. So if it is delivery before 34 weeks, so in singleton, it's 2% only, but in here, it's 22.67%, quite high. Delivery before 32 weeks, 8.2. In singleton, 1.3. Yes, it is again quite high. Admission to NICU, if it is 8, in multiple pregnancies, it's going to be 36. FGR, 7.6, 18.6, double than that. So what you will do in that? So we do, the scans, right? We do, in FGR, yes, we do have, the very beautiful guideline from Royal College. And yes, we do have a nice guideline as well for twins and triplets. So yes, we do have to go for the scans according to the recommendation by the guidelines. So maternal hypertension diseases, yes, itself very advanced maternal age is at risk of development of hypertension, preeclampsia and all. And if it is, associated with this twin pregnancy, then yes, ART will have its own implications as well. Yes. So yes, there are going to be 14 in singleton and 10 to 42%. So what you will do? How you will manage such women? Regular BP check in the 3rd trimester, because this is going to be the high time when women can develop, the high blood pressure according to the, the physiological changes that are going to be more pronounced in the last 3rd trimester. Maternal preeclampsia, 4.12 in singleton, it's going to be 26 to 32%. So what you will do? This is exam question, okay? Remember, and please write it down. This is very important. So how you are going to prevent this maternal preeclampsia? So you will advise low dose aspirin 150 milligram from 12 weeks of gestation until delivery. Okay, is it low dose? Aspirin 150 milligram. So what is the normal recommended dose? I mean, apart from this age group, how much do you give? 75 mg, isn't it? So you are giving double the dose. Okay, because you have to prevent this lady from development of maternal preeclampsia and yes, the late sequelae as well. So you will give 150 milligram from 12 weeks of gestation until delivery. Why 12 weeks? Anyone? Why not from the start of conception? Why from 12 weeks? Anyone?
It's because of the first trophoblastic wave of. Sorry. It's because of the first wave of trophoblastic invasion starts from this this gestation. Second wave is at 18 to 20 weeks. So you have to prevent the these trophoblastic changes. So you start from the 12 weeks. The first wave of trophoblastic changes, they start from 12 weeks. So it's like you start from the 12. Before giving 12 weeks, it's not it would not be beneficial for the patient.
Very good, brilliant. Okay, so side by side, you all have to offer, should we start offering? See, Maryada, what happens is that, like, I mean, I couldn't see the name of the candidate who brilliantly, explained this thing. Okay, because what we have to do is that, because second wave of the trophoblast is going to be completed by, the 18 to 20 weeks. Okay, so what are going to be the complications at the time of the second wave of trophoblastic invasion? So what do you mean by trophoblastic invasion? What will happen with this? Because, the maternal spiral arteries and the arteries which supply the new, the fetus as well, those are going to be dilated, those are going to be, the tortuous, those are going to be, there is going to be more permeability, more vasodilatation. So if there is any kind of problem at that point, so what will happen is the arteries are going to be constricted, arteries are going to be narrow, arteries are not going to be as functional as we need them. All right. So what will happen? So we will have, the placental abnormalities. So what are going to be the placental abnormalities? So we have got a couple of them. Okay. So we do have eclampsia, preeclampsia. We do have IUGR. Okay, and then we can have abruption as well. All right. In terms of your question, that if she's coming beyond 12 weeks, we can offer, okay, we can offer before that, okay, but we will counsel if we are in the setup where we have to talk to the woman, and this is what we do in our part 3 exams. All right. So then there is going to be one thing you can consider giving her. Okay, I'm sure, Maryada, I have cleared this thing in your, the sessions as well, that, in the NICE guideline, we have got 3 things: either discuss with the woman or the partner or the family, then either consider or, offer. Offer means you have to give anyhow. Consider mean, okay, yes, you can give and you cannot give. All right. And discuss means that, okay, yes, you can discuss all pros and cons of anything. And this discuss, offer, and consider we do see in the preterm labor guideline, moreover. But yes, your question is very good. Okay. Because, if she is coming beyond 12 weeks, you will still consider giving her low dose aspirin, because, probably this is going to give her, not like 100% effect or protection, but yes, it can give, somewhat. But it's not like that she's coming at 36 weeks and you are giving her 12, this. But yes, if it is beyond that, what I mean to say is from 12 to 18 weeks, then yes, it is going to help, but not after that. I'm sure, but not after that, because it's not going to affect after that at all, because damage has already happened. Okay, damage has already been done. So what are we going to, expect afterwards? Nothing. Okay, so always we have to balance each and everything. Okay, so the GDM, maternal preeclampsia, Now we will talk about this GDM. GDM in the singleton pregnancy, it's 8 to 23.8%, but in the twins, it's going to be even more high. So what you are going to do to nullify this, the problem, or to diagnose this problem, you will have you will have a glucose tolerance test at 16 to 18 weeks. Is it the normal gestational age, or is it, early or late? 16 to 18. Is it the, the normal gestational age in which, we do the OGTT?
No, it's early. It's early. Normally, we recommend at 24 to 28 weeks.
Yes.
Only in condition where there is history of previous GDM, you offer at booking. Otherwise, you offer at 24 to 28 weeks.
24
so
to
it's early.
28. Very good. Very good. Okay. So it is 16 to 18 weeks. So remember this thing as well as add 26 to 28 weeks of gestation to screen for GDM, because they are doing it, the 2 times. All right. Yes, normal is at 24 to 28 weeks. And so it is going to be early, 16 to 18 weeks. And then, yes, even if it is normal, they are going to do again. They are going to do it again, 26 to 28 weeks. Why? Because, yes, the changes can, occur later on as well. So, yes, even the early OGTT and then even here as well, because they really are concerned about this GDM in very advanced maternal age group. Then comes cesarean section delivery. It is going to be, if it is in singleton, it is 50%, but it is 79 to 91.8%. If you just round off, just for the sake of memorization, it can be even, the 100% as well, isn't it? 75 to 100%, you can say. So what you will do, you will have early discussion about the mode of delivery, obviously. So who is going to tell me, according to new antenatal care guideline, when you have to discuss about the mode of delivery?
28 weeks.
28 weeks, yes, very good. And when you will finalize the time and mode of delivery? 36.
By 36 weeks. 36 weeks.
36 weeks. You have to have a confirmed plan that when and how, and when woman is going to be delivered. After 28 weeks, see, the guideline says that at 28 weeks you will start discussing about, that how and when she is going to deliver. Okay, by 36 weeks you will have a clear management plan. Okay, because this is the high time when a woman can deliver anytime. Okay, so yes, this was clear. And now we will talk about that, what are going to be the maternal complications And this is very, the beautiful chart, I must say. And I'm sure all you guys know that from TOG articles, you shouldn't miss any of the, the charts, any of the algorithms, any of the diagrams. Okay? Because this is very much important. And I will, suggest all of you, for the people who are going for this exam, is that kindly, buy a, the printer of your own, and do try to print, whatever you see in the form of algorithms or, the tables, because this is going to be very handy. Okay, you can even take this at your workplace as well, while you are traveling, while you are moving here and there. So it is going to be very, the good for you, because, unless you don't revise things, this is not going to be, the easy, because curriculum is kind of never ending for part 2, I must say. Okay, so in terms of complications and risk, and how do you nullify in the woman with very advanced maternal age? So let's see. First, we will talk about the pre-existing medical complication, any of the maternal complication. So for example, the 44% is going to be for the woman who is 48 years or even more. So what you will do, you will have early referral to a high-risk antenatal clinic or maternal medicine clinic, because she is having maternal comorbs. So gestational diabetes, so it's going to be 12.6 to 21%, but it's going to be 35.1% in twin pregnancy that has, been conceived by ART. Okay, so what you will do, you will offer, the screening, what we have spoken about, but this is important. Women with very advanced maternal age are 9 times more likely to require insulin. This is a differentiating point. Okay, this is how you will highlight in your own notes as well. This is how you will write down in your own notes as well, isn't it? Because the women of very advanced maternal age are 9 times more likely to require insulin. Write it down, because this can be an exam question, isn't it? Because this is differentiating point, from the other gestational diabetes mellitus women. In terms of hypertensive disease, it's going to be 6 to 32%. So what you will do in such women? You will have pre-pregnancy counseling. Okay, you will have a review for antihypertensive medications and up to date of echocardiogram, renal function test, and renal imaging if they require. So who is going to tell me that if she is on ACE inhibitors or if she is on angiotensin receptor blockers, then and how you are going to stop, and with what drug you are going to replace?
You have to switch ACE inhibitors and these ARBs with the Aldomit if she's pregnant, Aldomit or Libitalol. Nifedipine is a good choice.
No, sweetheart. I can't see your name. Can you please tell me your name?
It's Sarah. Sarah.
Okay, Sarah, sweetheart. Now listen to me. Methyl dopa or the Aldomit is never a first choice. Maryada, this is not a good answer. Okay?
Libitalol.
So it is Libitalol. Okay. Always
Libitalol,
remember,
yes.
for every hypertensive disorder, you have to choose Libitalol. Okay.
Libitalol,
so,
yes.
Yes. So when you will stop this ARB and this AC inhibitors, my question remains the same. So when you are going to stop these 2 drugs, because this is very important, isn't it?
As early as possible. As early as possible.
That is a very safe answer, but for the exam perspective, guideline has given us a very clear idea that when you have to stop them, isn't it? So when you are going to stop, 1 month, Ala, is it? Within 6 weeks of pregnancy, everybody is guessing. So my dear all, it is like, you have to stop AC inhibitors or angiotensin receptor blockers within 2 working days of notification of pregnancy, and you have to offer alternatives as well. Okay, so remember, this thing is very much important. Within 2 working days of UPT, when UPT is positive. Why we are very much concerned about this? Why we want to stop this AC inhibitors and ARB?
Because of the teratogenicity.
Yes, very good. Because of the teratogenicity, isn't it? Because they both are associated with teratogenicity. So we have to stop them, because as early we have found out, yes, so many, isn't it? Plus renal agenesis, that is the basic, the contraindication of not using this, the angiotensin receptor blockers and this AC inhibitors. Okay. So yes, Along with, the skeletal abnormalities, they can be renal agenesis as well. So we have to stop them within 2 working days. Okay. See, or if the woman has had previous uterine surgery, for example, she has had, any myomectomy, any, the problem before, okay, any surgery on the uterus. So the chances of having the risk are 26%. So what you will do, you will have an early referral to a high-risk antenatal clinic. For placenta previa, there are 3 times more likely to have placenta previa than younger women. Write it down, guys, because this is very much important. Because I was reading this placenta previa guideline day before yesterday, so this was not written in that guideline. So it means this is a differentiating point, okay? So the 1 point and the 2nd point, highlight it. Highlight in your notes as well. So what you will do, you will have fetal anomaly ultrasound scan between 18 to 21 weeks of gestation. So yes, this is what we do. This is what we do. So those involved in scanning should be aware of the increased risk of placenta previa in women with very advanced maternal age. All right. So chances of PPH are going to be 25%. So they are almost 4 times more likely to need blood products than younger women. Okay. And this is going to be an important exam aspect for part 3 when you guys, inshallah, will go for part 3. Because these blood products and the how you are going to counsel about blood products is very much important at that time. So what you will do, you will have clear plans and precautions to minimize the risk of PPH should be discussed, investigate, and you have to treat the anemia like we do treat with all placenta previa. We will discuss the role of prophylactic eutrophonics in the management of 3rd stage of labor. Yes, we have to discuss. Then antenatal hospital admission, 30% risk in the very advanced maternal age group. Why? It can be because of any complication. It can be because of prematurity or GDM or preeclampsia or any of the complication. So if she is getting admitted for any reason whatsoever, what can happen? There can be chances of having, the VTE development. So what you will do? Thromboprophylaxis for women with very advanced maternal age with additional risk factors. Yes. And this we all know that, we have to consider thromboprophylaxis for the women who are being admitted. For example, if she has had OHSS, if she has had any pregnancy complication, if she has had, the nausea and excessive hyperemesis gravidarum, anything, yeah? So for any hospital admission, yes, we will consider thromboprophylaxis. So admission alone increases the VTE risk by 12 folds. Highlight and write it down, because these 3 points are differentiating point from the normal guidelines. So I believe these can be the important exam questions in the form of ENQs, in the form of single best answer or anything. So admission to the intensive care unit, it is even quite high, 33.5 times. Isn't it alarming? Yes, it is. Because it can be because of, any of the complications. So women are 33.5 times more likely to be admitted than younger women. So what you will do, you will consider offering care in a place with appropriate intensive care support for both mother and the neonates or the neonate. High-risk women of VAMA to be seen in the high-risk antenatal clinic at 30 to 32 weeks of gestation. If, for example, they haven't seen any consultant and they have been, offered a midwifery-led care. But yes, you will see at least once at 30 to 32 weeks of gestation. Plus, on-call consultant anesthetist should be made aware when a woman of VMA is admitted to the unit, okay? This is very much important because they have to be, very vigilant in terms of blood pressure. We have to be very vigilant in terms of, the preeclampsia at that time. Can't hear anything? I think you have to log out and come again, okay? Yes. Okay. Thank you, Rehan. Okay, all right. So is it clear to all of you? So if it is clear, then we will move forward. Okay, very good, Mayada. Mayada, I'm sure now you are not going to take this methyl-dopa as a first-line agent, okay? Hi, I'm so happy to see you. I'm so happy to see you. Thank you so much, Maya. Thank you so much. This is how I am. And this is how I do try to link things around, because this is very much important, until and unless you think links the link the things. So it's not going to give you an effective study, because whenever I study, I always think around so many things, around so many aspects, that okay, I haven't read this thing in my the regular guideline or green top or the nice guideline, because by the time I'm kind of the old, you can say that old MRCOG, because I have done MRCOG in 2019. So I have to revise each and everything again and again, just to keep myself updated. Okay. So these, the kind of, the sessions are not, going to help you, but it's helping me as well, because I am trying to keep myself updated at all times. So thanks all of you, because if you guys don't show interest, so we won't be giving any kind of, the webinars, or we won't be studying that much. Okay. So thanks to all of you. Okay, thank you so much. Okay, all right. So let's see. Now we will talk about that, what are going to be the effects of the fetal and neonatal morbidity and mortality. Okay. Earlier we have spoken about, this the maternal thing, and now we will talk about the fetal and neonatal morbidity and mortality. So what they say? They say the adverse perinatal outcomes in women with very advanced maternal age, the absolute rate of the stillbirth and the perinatal death is between 1 and 1.87%, compared with 0.55% in younger women. Isn't it high? Yes, it is. Because if we just talk about this stillbirth and the perinatal death, okay, this itself is a very, the kind of the grave situation for any woman there is, regardless of the age. But yes, in the advanced maternal age, it is going to be even more high. And I'm sure you all know that after 1.5, we have to round off, okay? Because sometimes in these kind of percentages, RCOG may not give you, the 1.87 accurate percentage. So they can give you even 2% as well, okay? So don't just look for this 1.87%. I'm just giving you an idea, okay? In all, the kind of percentage questions. All right. So perinatal mortality, okay, are 2 to 3.8 times higher in the babies born to women with very advanced maternal age. So write it down. This is also very much important. And as with women of all ages, prematurity, this SGA babies account for a significant number of stillbirths and early neonatal deaths in the UK. So if in question, if they're asking you that, in terms of perinatal mortality in VAMA, the births, so what are going to be the causes for, the perinatal mortality? So your answer should be prematurity. And if prematurity is not there, we will talk about this SGA, okay? Small for gestational age. Yes, 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 it is going to be recorded, okay? So don't worry, it's going to be shared. Okay, so what are going to be the high risk factors? High risk factors are going to be for the mother who are, the first time moms after 45 years, the mothers who are obese with black ethnicity, plus if they are having other comorbidities as well. All right, so I think these 4 risk factors can be very much important in terms of EMQs, because in EMQs they don't give you the clear, the answer. They do talk about, the multiple things in one question. That, for example, this is primary gravida. She has conceived with the ART, and now she is 48 years. She belongs to black ethnicity. Her BMI is 37. So what is she at risk of? So obviously there can be multiple risks. If the question is clearly about STA, if the question is clearly about, the VTE risk, then yes, we will think of so many things at that time, isn't it? So because the high risk factors, moreover, are going to be in the form of extended batch questions in real exam. Okay, so yes, primipara, obesity, black ethnicity, and other comorbidities, these are going to be important for the perinatal mortality, which is 2 to 3.8 times high in women in the babies born to women with VAMA, very advanced maternal age. Okay, so this is very much important. Down syndrome and aneuploidy risk. Because yes, already we are very much concerned about Down syndrome, isn't it? We are offering Down syndrome screening to every woman there is. Okay, but yes, for the VAMA mother, yes, we are going to be more concerned, because in women of VAMA who have conceived with their own embryos, okay, own embryos, it's not ovum donation, there is 95% detection rate of Down syndrome, which is higher than in any other age group. Okay, this is quite high. So using a cutoff of 1 in 150 at term as a screen positive result, 1 in 4 women of VMA will screen positive. So yes, this is even quite high. 1 in 4 mean it's going to be 25% straight away, isn't it? So 25% is quite a high number for any baby to be born with Down syndrome. So a screen positive result requires careful counseling. So we all know that if somebody is screen positive, so we have to offer, any diagnostic testing as well, isn't it? So I'm sure that all of you have gone through this, the new invasive diagnostic testing guideline in amniocentesis and chronic villus sampling. Okay, if not, just go through it. Although there are not, the major changes, but it's a good idea to be very much, the updated at all times if you are going for exam. So invasive diagnostic testing, amniocentesis or CVS can be offered. It gives accurate results, but has a small risk of miscarriage. Okay, so who is going to tell me what is the risk of miscarriage by CVS or amniocentesis? Anyone?
1%, it's, I think.
1% from? 1% additional, okay? Yes. 1% additional, 0.5%, 1 to 2%. It's a good answer, in fact. 1% additional risk of miscarriage, okay? And the latest guideline says it is 0.5%, okay? So remember, 1% was, even in the, the old guideline, because I think that was 2011, but this one is the newest guideline, okay? 0.5%. So remember this thing. Yes. So 0.5%, let me write it down so the person who has missed can even see it, okay? So NIPT, non-invasive prenatal testing, may be an alternative to invasive testing, but we all know that non-invasive prenatal testing is also a screening test. So yes, we can always offer, after this Down syndrome screening, this NIPT to only, the selected population according to the Down syndrome screening talk, isn't it? So yes, it can be an alternative to invasive testing. It detects 99% of Down syndrome cases and has no risk of miscarriage. Some women may prefer this option. There is a significant association between congenital anomalies and trisomies as well. Okay, and we all know that many of the first trimester spontaneous miscarriages, when they do miscarry, they do have the undiagnosed trisomies as a cause, because in the first trimester we do say that chromosomal abnormalities are the most important cause of miscarriage. Okay, so now we will talk about this antenatal care. Is it clear, everyone, up till now? Okay. Thank you so much. Thank you so much. Because this is how you are going to mix, you are going to, have your own mixed plate of the guidelines and the talks. And once you don't correlate, things are not going to be easy and things are not going to be clear for all of you. Okay. And this is my habit, because I always correlate things, and this is what I always tell to my all candidates, because this is very much important. Because this is not the one exam you are going to have. After this part 2, you are going to have part 3 as well. So your concepts should be crystal clear, I must say. Okay. So now the woman has become pregnant. Now we have dealt with the maternal complications, fetal complications, Down syndrome as well. Now how we are going to deal with such women? How we are going to give her antenatal care? This is also a very important aspect for us. Okay. So let's see. And I will again advise all of you that please get all these algorithms and the charts printed. This is very much important. Okay. Thank you so much, Adnia. Means a lot. Thank you so much. Okay, so we have said that, we will start our, the care from, yes, concepts are very much important. Unless your concepts are not, the clear, I must say. So part 3 is going to be a challenge for you. Okay, so please keep, if your concepts clear, study effectively. It doesn't matter, how you study and, the which group do you follow. But in the end, this is going to be your exam. In the end, only you are going to suffer if your concepts are not clear. Okay, so keep your concepts clear, keep your things in a way that, if you are revising, so everything should be in your mind, that how you are going to correlate, how you are going to think about in the retrospective way as well. All right. Okay. So in terms of BMA, we will start with preconception advice. We will individualize this to the mother and fetus. We will give folic acid 400 microgram or 5 milligram depending on the risk factors. Again, this is a very challenging question. Okay. In fact, I must say a very challenging thing that, what are the risk factors in which you have to give the high dose folic acid? Anyone? Because 5 milligram is the high dose, isn't it? And 400 microgram is the
epileptic patient, diabetic, epileptic, in a patient with the history of neural tube defects, you give the higher doses.
Yes, and you will give from
5 mg, 5 milligram.
From preconception care.
From preconception treatment.
Yes, this is what I mean to say is that, always, complete your sentence, because this is very much important. Okay. So 3 months preconception till 3 months post-conception, unless there are any concern, unless you think that where you have to, follow this woman with 5 milligram till delivery. But I think that's very special case. And I think the sign guidelines is for epilepsy, but RCOG doesn't recommend, if I remember from TOG article. Okay. So yes, 5 milligram, 3 months preconception, 3 months post-conception, moreover. So you will do medication review, you will optimize the BMI. BMI is very much important. Benefits of the single embryo transfer, we will talk about. This is also very much important, isn't it? So woman with pre-existing hypertension, if she is having, you will review antihypertensive medications. You will have up-to-date echocardiogram. You will do renal function test. You will do renal imaging as well. So you will not leave any loophole for the woman who is already VAMA and she is having comorbs as well. So it means you are going to bring this woman to such a good shape that when she becomes pregnant, she is going to be in a good shape of the health. Okay. So what you will do, you will have immediate VT risk assessment once pregnant. See, VT assessment at booking, or now they are saying once pregnant, because booking is going to be even more late, 10 weeks. See, this is also a differentiating point. So note it down. So there should be a clear pathway for women to assess prescription and support for thromboprophylaxis to ensure compliance. This is also very much important. In fact, compliance is very much necessary for each and everything. So low threshold for referral to early pregnancy unit in the light of increased rates of miscarriage and ectopic pregnancy. You will do VTE assessment after miscarriage or even ectopic pregnancy as well. You will do a booking appointment to establish, number one, method of conception, because we have to be very sure that whether this woman has conceived spontaneously or whether this woman has taken help of ART as well. Okay, so in both cases, you need to be very sure that you talk about this, whether, and this is what we do in part 3. Okay, when a woman is coming for part 3, so we do ask, I mean, no voice. I think I am clear. Are you guys facing any problem? Okay, okay. Thank you. Okay. Great. Okay, fine. So I think, Sarah, there is a problem at your end, sweetheart. So you have to come back. Okay. So methods of conception, you will make sure, not to miss this. Previous uterine surgery, if so, for early referral to high-risk antenatal clinic, discuss options and risks regarding mode of delivery. Okay, if my question to all of you is, why this previous uterine surgery is important? Why not? Okay, let it go. Why this previous uterine surgery is important? Anyone? For example, if I'm
Because
giving you
to decide the mode of delivery, like for example, if any woman have myomectomy, so maybe she will go for a cesarean.
She will go for cesarean, but in what case?
At 36 weeks you have to discuss, and 38 weeks plus you will go for CS.
To assess risk of uterine rupture, yes, I do agree with all of you, but my questions remain same. My questions remain same. That why are you very much worried about this? The previous uterine surgery.
Because a placenta excreta can be occurred.
Cavity intact or breached. Brilliant, brilliant, Maya. This is what I wanted to hear. Okay, because if the cavity, I mean, if you have breached this cavity, uterine cavity. So please don't mind my drawing, because this is how I can only draw on this. So if the cavity has been breached, so yes, there are going to be chances of whatever the complications you guys have said. Okay. So if cavity has been, the breach, then yes, there are going to be the chances of having uterine rupture, chances of having placenta previa, chances of having placenta previa, excreta, and all. If the cavity is intact, if the myoma was, the myoma was not deep inside the cavity, then yes, there can be, so in that case, what you are going to do, you are going to look for her previous record. So obviously, because we are studying for this MRCOG, so yes, we are going to, seek permission from her that with your permission, I would like to review your previous record. Or if you can recall that if some doctor has told you afterwards that, what exactly you have had at that time, okay, what kind of operation, you can clearly ask her, or you will seek, her permission as well. So yes, this is very much important, not if this in advanced maternal age, but to all, the age group for the women who are going to become pregnant. So you will do risk assessment, you will advise 150 milligram aspirin from 12 weeks until delivery. Okay. So please, this is very much important, because in, the exam questions, there can be, because earlier, I think years ago, they used to stop at 36 weeks. And I am really sorry to say that, many of the old school thoughts, the old, our fellows, they still stop at 36 weeks, keeping in view of, the bleeding at the time of delivery. But this is until delivery. Okay. So the multiple pregnancy, if that has been diagnosed in the first trimester, so what you will do, early referral, consultant-led, the hospital having the NICU facility that provide appropriate level of care for babies born prematurely, Vte risk assessment again, the LDA from 12 weeks until delivery. Plus, this is very much important, guys, because at the same time, if the woman is more than 35 years of age, plus she is having twin pregnancy, so yes, she is having 2 risk factors for small for gestation age, isn't it? So at the same time, you will have the other the biomarkers as well. You will have PAPE measured and neonatal, and you will note it down. If it is significant, if it is less than 0.4 multiples of median, important. If it is singleton pregnancy, again, you will do the early referral to the high-risk antenatal clinic, maternal medicine clinic if required. You will have PAPE measurement. You will request a serial growth scan at 28, 32, 36 weeks. You will do venous Vte risk assessment at every appointment or at the time of admission. This is important. Okay, at every appointment and admission. Okay. So then what you will do? You will screen for sorry, yes. So plus you will do the screening for GDM in the multiple pregnancies, and GTT, you will do GTT 16 to 18 weeks, and then you will repeat it again. Okay. You will have early discussion regarding risk of premature delivery, mode of delivery, place of delivery, role of steroids, and magnesium sulfate. Okay, again. And these are important RCOG questions. Okay. Not in the terms of multiple pregnancy, but yes, in terms of singleton pregnancies as well. So go through your nice guideline, very, and these should be on your tips. When to discuss, when to offer, and when to consider. These three things are very much important in terms of magnesium sulfate, in terms of steroids and all. You will screen for GDM with a GTT at 26 to 28 weeks, even if screen was negative for multiple pregnancy. And I think we have discussed. So you will do regular blood pressure monitoring and urine analysis as well, increasing in frequency in the third trimester of pregnancy. You will do VTE risk reassessment if hypertensive disease is developed or admission is required. So women with additional risk factors, for example, high BMI, multiple pregnancy, hypertensive diseases, placenta previa. So they should be referred to high risk obstetric anesthetic clinic, anesthetic. I will repeat again. 30 to 32 weeks of gestation, very much important, because you have to have a senior anesthetic input in that woman. Because according to NICE guideline, for the high BMI, you have to have early IV access, isn't it? You have to have, the continuous blood pressure monitoring and everything, which is very much important. You have to give her one-to-one monitoring as well in terms of midwife. Plus, you have to have an early anesthetic review once she comes in labor in terms of high BMI. So timing of delivery with multiple pregnancy to be guided by fetal surveillance and maternal risk factors. But there is no current evidence on the optimum timing of delivery. Okay, hang on. This is very important, the aspect. Because in here, in in singleton pregnancy, there is going to be, the aim when you have to deliver this woman, okay? You will again screen for GDM. You will screen again at 26 to 28 weeks, even if the initial was negative. Regular BP check and all, Vte reassessment and all, hypertensive disease develops or admission required, early discussion regarding preterm delivery and all like this, okay? Multiple pregnancy. Women with additional risk factors, again, it's the same, but the difference is here. Because in VAMA mother who is having singleton pregnancy, your aim is to deliver by 38 weeks of gestation to reduce the risk of stillbirth. You're not going to take her up till 42 weeks of gestation. But still, you will talk about each pros and cons and everything. But your aim should be very clear. Once you are going to do the counseling, you have to counsel her that, look, we understand that, you want to go for 42 weeks. But yes, according to the guideline, according to the the protocol, our aim is to deliver you by 38 weeks of gestation, because there are chances that that your baby might die in the womb, okay, and we have to reduce that risk. All right, so this can be an exam question as well, guys. Okay, 38 weeks, by 38 weeks you have to deliver her, and less than 36 weeks there are going to be chances of preterm labor in any group, either singleton or multiple pregnancies as well. Okay, so clear, everyone? Any questions so far? Clear, everyone? Very good. Very good. All right. All right. If you guys have any question, you guys can ask. Okay. And this is how we have finished our one TOG article. Okay. Just give me 1 second. Okay, so that's very good. So I hope after this session you guys are going to be very clear in this thing, that at least very advanced maternal age. I hope you're not going to read it again, okay? Because these are important TOG points which I had expected, okay, which I think are very much important in terms of when you compare so many things. So this is good. So we are good to go for second. Let me check my the message. First 2 slides. Okay. Hi Eliza, welcome. Okay, let me share. Okay, this is the definition. Okay, and This was that, how these women are going to deliver. Yes, Sir Hassan. Why are you raising your hand? Please, please, please. This is my honor to have you.
Hi, Dr. Zaib. How are you?
Hi, sir. I'm good,
Is my
alhamdulillah.
voice audible?
Yes, yes, yes. It's very much audible.
Yeah. Yeah, perfect. So, thank you so much for this wonderful session. Actually, I enjoyed every moment in this session, and
Thank you so much.
I'm here between the wonderful candidates for a long time. Actually,
Yes.
very informative, very simple, very clear information. I think the TOG articles you discussed today are important, new, and I hope next sessions with the TOG articles will be also beneficial to all candidates. I would like to say hello to all candidates as well from mid-exam expert. I think the TOG articles nowadays are very important, maybe more than the other guidelines, because
Exactly.
the guidelines are killed by previous exams, okay? But the TOG articles are abundant and is a very good field to extract different questions. So we need to be very careful in next exams for Part 2 MRCOG regarding the TOG articles. And this is our idea about this. So thank you again, Dr. Zaib. And I would like to thank everyone attending this free session. Thank you so much. And proudly and behave on the mid-exam expert, Dr. Zaib, Dr. Helmi, and me for the crash course.
Yes.
I will be very happy to offer a great discount if you would like to join our course. We will be proud. We will be happy to join our course. And of course, our work for free to all aspirants and warriors of Part 2 MRCOG and Part 3 as well is continued, because this is the policy of mid-exam and we are proud to be a part of this organization. Thank you so much. And again, keep on moving, don't stop, never give up. You all will be one day MRCOGians. Thank you, my dear Dr. Zaib. Thank you so
Thank you
much
so
for
much,
these
sir. Thank you so
few
much.
minutes. Thank
It
you.
was great having you here. Thank you so much. It's my honor, in fact.
Yeah, no, don't
Thank you
say
so
that.
much.
I enjoyed a lot, believe me. And
Thank
I
you so
think all
much.
candidates enjoyed your session because you are
Means a
so
lot.
much talented and so much, you know, you will never feel bored when I listening to you as well. So thank you again, Dr. Zaib. Thank you.
Thank you so much. Thank you so much. Thank you
Excuse
so much,
me.
sir. Yes, yes.
I'm Dr. Saima. I want to say thanks really for Dr. Hassan and for you also, the discussion going on. I want to ask that you are saying that there is a discount. Do you think that we are in the course already? Do you think that we should join the crash course also? Because I'm still not in the way, I've not done all the course still, because still the schedule is going on and there's something new remaining even. So do you think we should go for the crash course also?
Saima, I think you can go, because in the crash course, obviously, we are going to be with you, and there is going to be rapid revision, twice a week classes, every week, the twice a week classes. So obviously you are going
Because
to be in the
in this
flow.
session also the
Mhm.
classes are going on, then again there will be 2 classes more. I think it will be not be overwhelming, and I think more
Oh, it's going to be
occupying
so
and everything.
helpful. It's going to be so helpful because I can see you are, the kind of, the candidate who are eager to learn. So what I believe is that, you are hardly, how many weeks left? 7 weeks, I must say. So in
Yeah.
7 weeks, so yes, you have to do, isn't it?
And will there be any discount who is already in the course for them?
Yes, yes. And you won't believe, while I was, talking to all of you, just, I got so many messages on my, the private inbox, on the messenger as well, that please, 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 give us. So I already had, this surprise to all of you. So yes, there is going to be a kind of, the massive discount for everyone. And Saima, I mean, you can talk to me later, okay? After webinar.
Okay, thank you so much. Yeah,
Don't
thank
worry
you
for
so
that.
much. Thank you.
Okay, my
Thank you
love.
so much.
Okay. Okay, thank you so much, Dr. Hassan. Thank you so much. Pleasure having you. Thank you so much, Rehan. Thank you so much. Thank you. Okay, so I will just take your few moments just to give you this, the news that, how we are going to support you all. And this is apart from this, the the learning, ongoing learning. Okay, I'll be taking on and off classes, and probably perhaps, for every fortnightly, I will try to take, the one Facebook Live as well with all of you in your, this Facebook part 2 guide group. Okay, so I'm always there. Like I always say that I'm always reachable, that whenever you guys have any kind of issue, anything, you guys can, reach out to me. Okay. So thank you so much, Rehan. I'm very much overwhelmed. Yes. Thank you so much. Thank you so much. Okay, so I will just take your few moments and then we will move on to our second talk article. Okay. So how to start the focus preparation now? This is a very, the important and, the very good question, because hardly we have got 7 weeks left. So yes, I mean, journey is not easy. It is not like, I mean, kind of impossible thing when I can become an MRCOG, okay, when I can do everything, okay, so you guys equally can do, okay. Never think that you guys are less than anybody. Circumstances can be different, circumstances can be difficult for, everyone, but it doesn't mean that you guys are less capable, you guys are less, the kind of, the deserving candidate for becoming MRCOG, okay. So as a team, apart from this ongoing learning, apart from all these, the help, because, we do work for med exam as well. So yes, because as a team, me, Dr. Hassan, Dr. Helmi, we have decided to do this crash course in a very effective way to give, the candidate maximum input. Okay. So we are going to have, the very exhaustive, the kind of this crash course. Okay. This is going to be rapid, the learning. You will have course session recordings for revision of all topics. When we say all topics, it means you will have all topics revision. You can, plan, you can time out yourself, and you will have, the online sessions with us as well. You will have TOG article summaries access, the updated from 2012 to 2021. You will have flashcards as well. You will have study room with all of us. Okay, me, Dr. Pradnya, Dr. Hassan, Dr. The Helmi, we will be there. Okay, 24/7, we will give you support. And yes, apart from this course, we are always reachable. You guys are more than welcome to discuss anything with us as well. So live sessions for the discussion, this is going to be very much important because we are going to discuss these exam-like questions with you all. So we will try to work on your approach towards solving questions with references in live session. So moreover, it's going to be 6 weeks hassle, or I must say the hurdle as well. It's going to be a kind of, the roller coaster ride with us, because you guys will be having almost, twice weekly sessions. You will be revising all these things. You will be with us in the study room. You will be discussing, you will be solving. So I don't think it's going to be, the impossible to pass this exam. All right. So, so yes, this is going to be, this is another help. Okay, this is from the med exam that they have given GTG exam packs with all flashcards, written summaries, all, the summaries, every summary there is. Okay, so this is going to be in the form of written, so you can plan out your own, anything. So you can have, I think this is very reasonable. At, when we were studying back in 2018 and 17, we didn't have any kind of help, trust me. So we used to study ourselves, we used to make our notes and anything. So I think with all these help available and with your own, the studies, I think you can easily, pass this exam. So yes, for these talks and GTG summaries as well, everything will be there. So easy to memorize, the points are going to be there. So you can always, log into Med Exam Expert website and you can have, whatever you want to have any help. So apart from this, even if you need any kind of help, you guys can always reach to us. Like Dr. Hassan said, like I'm there, Dr. Pradnya is there, Dr. Helmi is there. So please, you can always, come to us and talk to us. regarding this TOG and GTG questions, okay? And I think this is an exciting, the thing to just, go about in just $25. All right. So you can have all TOG questions, and it's going to be according to the new format. So you will be having online computer-based tests. Okay. You can take as many time as possible. And I think there's going to be, but it is going to be time bound. All right. And this is very much important for the crash course. Okay. This is a very, the special discount, and this is a gift from my side. Okay. So I will get a coupon for all of you guys, and I think backend team will help me by giving me the coupon. So I can give you that coupon as well. So if you guys want to do this, so you guys can write my name along with this, the 199 and off 259.51. So yes, we will share coupon by the end of this session. Okay. So anybody who wants to take, and I think this is pretty reasonable, the fee to be enrolled in such, the exciting offer, that you will have, the one-to-one support, and yes, you will be having very vigilant monitoring on your preparation as well. Okay. For the candidates, for the July candidates, because, the many candidates who are still left for July, so you guys can, enroll yourself in the July 22 batch as well. So you will have, live sessions, study group, session recordings, module-wise organized schedule, everything, summaries, and the videos, and important FSRH PDFs, BASH guidelines, module-wise curriculum, 24/7 technical support. And this, trust me, this kind of technical support you will not get anywhere, because these people are so efficient and these people are so helpful, and they are working 24/7, I must say. So you will have course access till exams, okay? And the course is going to be started once the January course will finish, okay? And yes, you will have, this is very much important, because the topic tests are going to be there for all modules. You will finish one module, you will go for, the one module wise mock. Then, the next module, then next mock, okay? So this is, the kind of very overwhelming response from some of the, the candidates who had been with us, with me, Pradnya, Dr. Hassan in our September and July batch, okay? So yes, these are very overwhelming feedbacks. This again, okay, and many of them are with us in part 3 as well. So yes, and we are very happy that, we are part of their, complete journey of becoming MRCOG. Okay. So this is for July. This is for July from my side. This is going to be, the fee is again reduced. And I hope that, the team will share the coupon code with you all. Okay. And yes, you can all, go through this customer support from, the given number, which is shown on this, the slides as well. So you guys can, have any kind of, to contact. You guys can even reach out to me. If you guys want to have any help, apart from these courses, I'm always there. Okay. So thank you so much for being so patient. And apart from that, if there is any question regarding this. Okay, Andaleep, yes. Please, backend team, can you please help Andaleep? Can you please send her message? Okay. Yes. You can pay in installment as well. Okay. You can pay in installment as well. Yeah. Hi, Najat. Very good. Very good to see you. Very good to see you, Jen. Very good. So please, backend team, reach out to all these candidates. Please facilitate them.
Can I give feedback about your course?
Sorry. Yes.
Can I give some feedback about your course?
Yes, why not? Please.
When I have joined this course, though I haven't appeared in the exam yet, but I found this course very helpful. All the teachers, all the mentors, they are very dedicated. They make the things very simple. So I recommend this course for everyone. back in 2013, when I first appeared in this, I first appeared in the exam, there was no such courses, and it was very difficult. There was no, everyone was saying that if to pass MRCOG, you must have to be in UK and you must have gone through their system. But these courses have made the things so simple, so easy. The curriculum, I must say, this course is offering is very crisp, very directed, simple. Modules are very clear, and it's all exam oriented questions, and all the sessions. I must say the recordings, because due to the dedicated I'm highly committed person, like in the clinics and having my hospital, I hardly have any time for the study. So these recordings are really helpful. Dr. Hassan is a very good teacher. Dr. Zaib, Dr. Predna, they all are very good teachers. They like, they know, they are experienced, and they know how to deliver their things. So I highly recommend this course for everyone. And there is a backend team which they are all 24/7 available, and they are like magic. Like if you have any difficulty, they are there and they guide you, and then they help you. So so I must recommend this course for everyone. Like, this is helping me, so I say this would help all the candidates who are there to have some guidance, and they want some guidance. So this course is highly for those students. Thank you so much.
Thank you so much, Sarah, for being so generous in giving this, the kind words. I'm highly obliged. Okay, thank you so much. Yes. She can pay in installment. Okay, she can pay in installment, and all of these queries can be solved by the team. Okay, and if something is not clear, please do talk to me.
Hi, Dr. Zaib. Can you hear me?
Hi. Yes, I can.
Dr. Zaib, I just passed my Part 1 exams with you. And I just wanted to say that please enroll me in your July 22 course.
Okay, for sure. Can I ask your name, please?
Yeah. They said Andalib.
Andalib. Okay, my dear. Okay, for sure. Okay?
Yeah,
for sure.
please.
I will ask. Please do send text, or even you can contact me on WhatsApp or on Messenger, or any Telegram as well. Okay? I'm there.
Yeah.
So you can always talk to me.
You.
Okay, fine. Okay, guys. So let's move on to our next, the TOG article. Regarding course, I will be there. Okay, I will be facilitating you, and me, Pradnya, Dr. Hassan, Dr. Helpi, anyone from the team as well, Mafia, Umaima, okay, Muhira, Asma, and everybody from the med exam is going to help you. Okay, so please do talk to them. If you guys face any kind of difficulty. So wow, thank you so much, Zeen. I'm overwhelmed. Thank you so much. Oh yeah, sure. We will add you. Okay, don't worry. We will add you in study group. All right, so let's move on to our next blog article, guys. So we will try to correlate, because maternal medicine is my favorite thing, and if time and if everything allows, I really want to do my specialization in maternal medicine. Okay, so inshallah, I will try to give you an overview of this, the very important exam aspects of this, the article as well. Okay, so let's talk about this important aspect, because recently in the September exam, in the September exam, there had been so many questions from pancreatitis in pregnancy. Okay, so this is very much important talk. So I thought to bring this article, and I thought to discuss this with you guys as well. So let's get started. Okay, so in terms of this acute and chronic pancreatitis, so we all know that we have got two terminologies. Okay, acute, which is going to have acute sign and symptoms, isn't it? And then chronic, then what we have to do in chronic. Okay, let's talk about this acute pancreatitis. So we all know that it's an inflammation of the pancreas. It can be acute with sudden onset, or chronic, that can be caused by repeated episodes of pancreatic inflammation and the resulting pancreatic dysfunction, obviously. So what can happen more? The incidence of acute pancreatitis in pregnancy is rare at around 3 per 10,000 deliveries. Write it down, guys. This is very much important because in terms of incidences and prevalences, some of the incidences are very much important. Okay, so write it down. So the chronic pancreatitis has an annual incidence of about 5 new cases per 100,000 population per year. 5 new cases. It means the inflammation is going to be ongoing, the inflammation is going to be there, so it will cause repeated episode of pancreatic inflammation and pancreatic dysfunction as well. Then acute pancreatitis can be life-threatening at any stage of life. It is seen in up to 3 in 10,000 pregnancies with high rates of preterm delivery and maternal mortality rate of 3%. Write it down. Important exam question. Okay. So it can be seen in 3 per 10,000 pregnancies. Okay, this is going to be incidence, and the rate of preterm delivery and maternal mortality is 3%, which is quite high, isn't it? So the features of acute pancreatitis, this is very much important. Acute pancreatitis is more common with advancing gestational age and postpartum as well, which coincides with the increasing frequency of gallstones in pregnancy. This was exam question in September 2021. 50% of the cases are caused by gallstones, 25% are going to be with alcohol, and 25% are going to be with other causes. The commonest presentation is going to be sudden onset upper abdominal pain, most often located in the epigastrium and radiating through the back. In pregnancy, you can just imagine that because of the physiological changes, because of the very much reflux and everything. So how difficult is going to be for a pregnant lady if she has developed this acute pancreatitis, isn't it? So it is often accompanied by anorexia, nausea, and vomiting. So how, when a woman is coming to you with such, when we were doing our, the surgery rotation, so, we used to see these acute pancreatitis patients, they used to roll on the bed or even on the floor because the pain is bad. Okay. And we used to say that rolling over the floor or bed is the, the kind of sign of acute pancreatitis. So because it is there is going to be, the epigastric pain and radiating through the back. It is often accompanied by anorexia, nausea, vomiting. So how, what findings you will find on examination? You will have epigastric tenderness, you will have reduced bowel sound. Patient can, because it is acute inflammation, patient can present with fever and tachycardia. So the low-grade fever is most commonly related to systemic inflammatory response rather than infection. Okay, so low-grade infection. And what is systemic inflammatory response? Systemic inflammatory response is the spectrum of sepsis, isn't it? In which there are going to be early changes of the sepsis in there. The hematological changes, biochemical changes, physical changes and all. So this is going to be low-grade fever. We do say that yes, if the low-grade fever is there, that is going to be the, the sign of sepsis, impending sepsis. This is now important, that how you are going to diagnose. This is very much important. So before that, we will discuss that what are the causes of acute pancreatitis. Few we have discussed earlier that gallstones are over 50%. This was exam question. Okay. Alcohol, hypertriglyceridemia, or it can be idiopathic as well. It can be drug induced with the help of thiazide diuretics. There can be hyperemesis gravidarum. There can be acute fatty liver of pregnancy. There can be hyperparathyroid, gene mutation and association with severe HELLP syndrome. Okay, so please just go through these causes, because somehow we can miss some of the causes, but yes, this is very much important. Okay, so how do you diagnose of the pancreatitis? So from the diagnosis of the pancreatitis, you have to have 2 out of 3 criteria. Number 1, there should be abdominal pain, typically epigastric, that radiates through the back. There should be serum amylase or the lipase. This is very much important. More than 3 times the upper limit of normal, usually more than 300 units per liter, the same as non-pregnant patients. So there is no any change from the non-pregnant groups. Okay, 3 times the upper limit of normal. So please, this was exam question. So characteristic features of pancreatitis in imaging as well, that you do see, you know, some of the typical features of pancreatitis on imaging means ultrasound. So investigations, now comes the investigation. You have diagnosed, you have gone through all and everything, okay? So how do you talk about these investigations? You will talk about blood test on admission and at 48 hours. Okay, you will have blood test on admissions and at 48 hours. What blood test? Arterial blood gases, full blood count, urea electrolytes, liver function test, bone profile. Why bone profile? Because we have just seen that there can be hyperparathyroidism that can lead to what? Calcium and phosphate abnormalities. So that's why you are going to have this, you know, the bone profile as well. Lactate dehydrogenase, C-reactive protein, glucose. Glucose is very much important for even liver diseases. Which liver diseases? Which liver disease? You want to check this glucose. Which liver disease you want to check?
Acute fatty liver.
Yes, acute fatty liver of pregnancy. Okay, this is very much important. Acute fatty liver of pregnancy. Okay, what do you see in that? Hypoglycemia. Hypoglycemia. All right, and that hypoglycemia can be even, you know, the dangerous, because because we all know that our brain utilizes the glucose as a metabolite for the source of energy. If there is no glucose, there can be, you know, the deleterious effect on body. So this glucose is going to be equally important in this pancreatitis investigations as well. So daily blood test only required if parameters are abnormal. This was EMQ, I believe. Okay, so imaging. What kind of imaging you do? You do ultrasound abdomen to look for gallstones at first opportunity after diagnosis, because you have clinically diagnosed, you have made your, you know, the differentials. You have all differentials in your mind, and then you will look for so many things. You will consider CT, MRI after 5 days if concerned about complications are there. Please note it down. Never choose CT, MRI as a, you know, the initial modality in any, you know, the disease. Advanced, you know, I can say advanced imaging. Okay. So other tests, lipid profile if no gallstones seen. This is also very much important. The assessment of severity of acute pancreas. Score 1 point for each parameter present. A score 3 or more puts the patient at risk of severe pancreatitis. So you do have, you know, the 2 scores to do the assessment of severity. Modified Glasgow scoring of risk, or Atlanta criteria of the severity of the acute pancreatitis. Okay, so for the modified Glasgow, they have given a mnemonic, which is Pancreas. Okay, so Pancreas. So just remember, for the pancreatitis, you are going to have Pancreas in your mind, but not the E in the end. Okay, so from the P means saturation, partial pressure of oxygen. Okay, so partial pressure of arterial oxygen is less than 8 kPa. Age is more than 55 years. Okay, but not in pregnancy, of course. Okay, so neutrophils white cell count is more than 15 per, you know, the 10 raised to power 9 per liter. Calcium less than 2 millimoles. There is urea more than 16 millimoles. Enzymes lactate dehydrogenase more than 600. Albumin less than 32. Sugar more than 10 millimoles as well. Okay, more than 10 millimoles, because, you know, the pancreas and the liver are not working at all. All right. So pancreas is very much important in terms of modified Glasgow scoring. So you will give score 1 for each parameter. Score 3 or more puts the patient at risk of severe pancreatitis. So if somebody is having arterial, moreover, we can see this, you know, this kind of parameter, and even, you know, the enzymes. So yes, she will be at high risk of development of acute pancreatitis. All right. In terms of Atlanta scoring, so what you will do? Okay, you will have, you know, the Atlanta criteria of severity. If it is mild or moderately severe or severe. Mild means no organ failure, no local or systemic complications. Moderately severe, transient organ failure less than 48 hours, or local or systemic complications without persistent organ failure. Severe persistent organ failure for more than 48 hours. This puts at high risk of development of mortality and morbidity as well. Okay, single or multiple organ failure as well. This is very much important. So Atlanta criteria, mild. See, this is not even moderate, yeah? It is moderately severe. It means they are not even taking this moderate as a moderate itself. They are taking it moderately severe. So the next criteria is severe. So yes, they will have assessment of severity of the acute pancreas. Now they will do the management. We all know that the one is pregnant, lady is pregnant, and now she has had acute pancreatitis. So what you will do? You will have MDT approach, multidisciplinary team approach, in which you will involve senior consultant, senior medical specialist. Okay, you will involve, the senior, the ICU specialist, ITU specialist. Okay, senior midwives, dietitian. Okay, anyone who can be of help in this acute condition. Yeah, so you will put the woman in the HDU or ICU depending upon the situation. You will put the woman on IV fluid to keep up with the third space loss and to maintain an adequate urine output. You will give her analgesia. Many patients require opioids as well as simple paracetamol. Venous thromboembolism prophylaxis. Okay, hang on. Who is going to give me that? What is the preferred, the analgesia in pregnancy and postpartum? Question. Anyone? Any idea? Paracetamol, yeah. Paracetamol, yes. Preferred. Is it preferred or is it the common analgesic we get? Yes. Paracetamol. Pethidine in labor. Ibuprofen. Yes. Brilliant, Saima. Brilliant. I knew you knew this. Najiba, very good. Ibuprofen, okay? So ibuprofen is the preferred postpartum analgesia. And even if, the analgesia ladder, which hasn't been covered by this, the paracetamol only. So yes, even in pregnancy, you can consider low dose ibuprofen according to the TOG article, according to the scientific impact paper as well. Okay. So remember, for this ibuprofen analgesia, this is the preferred analgesia. All right. Great. So Vte prophylaxis, because the patient is admitted now, patient is pregnant patient is having acute conditions, so you will have Vte prophylaxis. You will put her on nutrition as well. You will give oral intake. If the patient is unable to eat, then passing an NG or nasovaginal tube for feeding is preferable to total parenteral nutrition. Why? Because triglyceride levels will reduce by a period of NPO or using off the sliding scale. Referral to an endocrinologist is advised as well. Because in this, now you need, the extra help in terms of, the other specialties as well. You will put the patient on antibiotics, but only for those patients with proven infections, remember, because you have to justify each and every action of yours. All right. You will do imaging for complications if you think they are suspected. You will treat the complications if there are any. You will modify all risk factors to prevent the further episodes. And what are those, the risk factors? Because we have seen earlier that, the gallstones are there more than 50% cases. So you can think of laparoscopic cholecystectomy. If you need to go for cholecystectomy, when you will do? Okay, you have to do within 2 weeks of index admission and preferably from 12 to 24 weeks of gestation or even after delivery. Why? Because this is the preferred time when you can put, the laparoscopic port in a woman because the uterine size is less. There is not going to be decompensation. Okay, there is not going to be more respiratory distress, keeping in view of the, the enlarged uterine size. So yes, you will think of laparoscopic cholecystectomy. Plus, we have seen earlier that alcohol was 25%. So you will advise about alcohol. Then we have said that there can be problems with the lipids as well. Basically triglycerides. So you will manage lipids too. Okay. Plus, you will have a very low threshold for the referral to the critical care for the organ support where necessary. Because if the woman is having, a lot of sugar complications, either low sugar or high sugar, then yes, You need to go, if the patient is having VTE, if she has developed any acute complication after having admission. So yes, you need to involve, the other specialties as well. All right. So remember MDT approach. Just remember that what you will do if you are dealing with any acute condition. So obviously, this is going to be helpful. So after that, for every patient, we do think of MDT, we do think of IV fluid, we do think of analgesia, we do VT risk assessment. In terms of this, if the woman is having a lot of vomiting, a lot of anorexia, abdominal pain, epigastric pain, so yes, we will be thinking of nutrition as well. Antibiotic only if there are infections. Imagine if there are complications. We will treat the complications there and then. We will modify the risk factors as well. All right. Or we will have a referral. We will have a very low threshold for the referral for the critical care, for organ support where necessary. All right. So what can be the complications in acute pancreatitis? There can be acute pancreatic fluid collection. There can be pancreatic pseudocyst formation. There can be acute necrotic collection and walled off of the necrosis. Because let me show you the anatomy first, okay? So this is the pancreas, okay? If there is a lot of inflammation, so what will happen? There can be, the pseudocyst formation in the pancreas as well. There can be, any kind of complication. There can be, if the irritant is still there, if the problem is still there, if somebody is having alcohol, if somebody is having, the gallstone as well. So yes, in that case, there can be a lot of complications as well. So yes, you have to do cholecystectomy, you have to remove this, and then you have to think of, the other things as well. So in terms of complications, there can be local complications, okay? So the pancreas itself can have, a lot of complications. The regional, in the body, there can be gastric outlet dysfunction, because if there is swelling of the head of the pancreas, it is going to push, the stomach as well. Okay, posterior wall, there can be, the splenic and the portal vein thrombosis. There can be colonic necrosis as well. All over systemic, there can be worsening of the non-comorbid condition. For example, if the woman is having ischemic heart or the lung diseases as well. So altogether, it's not like that it is just going to affect pancreas, but yes, it's going to affect almost, the locally, regional organs and the systemic, the response as well. Okay. Thank you so much, Bino. Thank you so much. Means a lot. Okay, so now the woman has developed acute pancreatitis. So what we can think of to this woman, obviously, for every acute inflammation in pregnancy, we are having a fear of preterm birth, isn't it? With acute pancreatitis, we will have preterm birth 15 to 32% and significant fetal mortality as well. Based on higher premature delivery rates, the use of steroids for fetal lung maturation should be considered. See, it is considered. It is not like that woman will enter and you will start giving her steroids there and then. No. If you think that she is at risk of development of preterm birth, then yes, you may consider. There is also no contraindication to giving a magnesium sulfate infusion for neuroprotection of the premature infant. Okay. And when do you give magnesium sulfate? At the start of admission, at the start of labor, or when? Anyone? Yes, labor. Which labor? Active means when she is established labor. Established labor means now she is more than 4 centimeter dilated, and the chances are that she can deliver within 24 hours. Okay, when there are predictions that she can deliver anytime, within 24 hours. So in that case, you will consider magnesium sulfate. Okay, so remember, this is also very much important. So the decision to deliver must consider both the gestational age and the severity of the pancreatitis. Delivery should be considered if there is clinical deterioration despite 24 to 48 hours of active treatment in moderate to severe cases. Okay, so this is the condition where you have to stabilize the woman first, and then you need to take the step to deliver, because certain changes of the pregnancy can limit our the treatment options for the pancreatitis as well. So If the patient is not, improving after 24 to 48 hours, then you may consider delivering her even early. Okay, moderate to severe cases. Okay, clear for acute pancreatitis? Any question? Any query? Okay, great. Good, good, good. I hope it's clear to all of you, yeah? Okay. So now let's talk about this chronic pancreatitis, yeah? So chronic pancreatitis is progressive inflammation of the pancreas causing irreversible damage of the parenchyma that leads to endocrine and exocrine dysfunction. See, the word is irreversible. In questions, they may confuse you by giving reversible damage. Okay, so be extremely careful. Because the pancreas, physiologically and chronologically, pancreas has two types of, the function. It do have endocrine function and exocrine function as well. So chronic pancreatitis will have endocrine and exocrine dysfunction. So the development is going to be multifactorial, but the most common causes are alcohol and recurrent episode of severe acute pancreatitis. Write it down because this is exam question. Okay. So the chronic pancreatitis cause alcohol. Second, recurrent episode of severe acute pancreatitis. So abdominal pain is the most common symptom of acute pancreatitis. Exam question. So abdominal pain is going to be severe enough that require regular opioid analgesic. So what do you do in that case? A multidimensional scale such as McGill Pain Questionnaire is a more appropriate assessment in these patients. Okay, so this is exam question. This is exam question from chronic pancreatitis. So consequences. This is very much important. So what will happen in terms of the consequences of chronic pancreatitis? There can be exocrine pancreatic, the insufficiency, endocrine insufficiency as well. So exocrine, so there can be the pancreatogenic diabetes mellitus. There can be exocrine dysfunction that will manifest as diarrhea, bloating, cramping with meals, abdominal pain, steatorrhea, weight loss. Fecal elastase can be used to evaluate pancreatic secretions but may not detect mild to moderate insufficiency. Alternatively, what you can do is a trial of pancreatic enzyme replacement can be used. The dose of pancreatic enzyme replacement may need to be increased in pregnancy. Vitamin supplementation must also be considered. Involvement of the nutrition team is also adjunct. In terms of endocrine, insufficiency, in chronic pancreatitis, it is very much complex. Why? There is going to be reduced insulin production, increased insulin resistance, or the combination of two. So the pregnant woman with a history of chronic pancreatitis should have an OGTT arranged at booking. Okay, please write it down. This is very much important. Okay, OGTT at booking. Now this is a bit different than VAMA, what we have discussed earlier, isn't it? If not previously diagnosed with diabetes, because the woman who is having chronic pancreatitis must be having this, or she may be having at risk of development of diabetes, because there is going to be absolute deficiency or insufficiency of insulin, isn't it? Because insulin is produced by pancreas. So early involvement of specialist diabetes team is advised in that case, of course. So how do you manage such cases? So first of all, we have seen earlier that alcohol is a major culprit. So if the woman is smoking as well, so you will, consider advising from the abstinence from alcohol and smoking. And that is strongly advised and has been shown to improve pain. See, because the abdominal pain is the most common symptom of chronic pancreatitis. So what you have to do is you have to reduce pain first, and then you have to deal with the consequences. Okay, so the regular use of opioid and related tolerance may also affect the choices and doses of analgesia in labor, because we all know that opioid has, some kind of dependence, some kind of tolerance as well. So we need to be very careful in that case, number one. Secondly, because it's going to be affect what we are going to offer analgesia in labor, plus the baby effect as well, the neonate. Okay, if the woman is on regular opioid analgesic, the baby can have withdrawal effect after birth. So we need to be very clear. Everything should be, written on the notes of the woman as well. And if the woman comes in labor, this should be very clearly documented on top of, your notes. Plus, when you are giving any handover, so you have to give this, important piece of information to your colleague as well, that this woman is on so and so of the opioid. So yes, we need to be very careful in terms of withdrawal of the neonatal withdrawal symptoms as well. All right, because this is very much important. Okay, so thank you so much for your patience, everyone. So is it clear to all of you regarding these two TOG articles, important exam aspects as well? If there is any question, please ask.
As regard the ibuprofen analgesic during pregnancy, better to avoid in third trimester. True or not?
Ibuprofen,
Yes.
you said that it's better to avoid in?
Third trimester.
Yes, it is.
Okay, because you told it is the best analgesic during pregnancy.
No. See. I said postpartum. Okay. Postpartum, it is, the preferable analgesia postpartum. And even in the ladder, pain ladder, okay, the treatment ladder, analgesic ladder, you can say in pregnancy as well. Because your first choice is going to be paracetamol, okay. Second, you can go for low dose ibuprofen as well. All right, you can go for it. Yes.
Thanks.
Algorithm of painkillers. Okay, I will try to summarize this TOG article. Okay, I will try to summarize this TOG article and send you guys. We have got TOG article on pain relief. Okay, and second, we have got scientific impact paper of the pain relief in the pregnancy and postpartum. I will try to make a good combo of these both, and probably I will share with all of you. Okay, in coming week, inshallah. Okay, thank you so much for your patience, everyone. If still anything is not clear, please do ask. Any query, any ambiguity regarding exam preparation or anything, okay? Thank you so much, Lina. Thank you so much. I'm so happy to see you all here, learning and growing day by day, okay? And apart from this, I'm always reachable. I'm there, okay? So do reach out to me, do talk to me whenever you want to. Can do lap cholecystectomy during index admission? Yes, okay. Now, Lisa, see, the patient is in the first trimester, okay? She is almost 10 weeks of gestation, okay? And now she is with us with acute pancreatitis. And we have found out from the scans and everything that she is having gallstones as well, because there is 50% of this, the association, yeah? So with this, we may think of that, for the acute pancreatitis, certainly we will admit, okay? We will admit her, yeah? So if we have admitted, we have found out she is having gallstones and her gestational age is from 10 to 22 weeks. So what happens in that case is, so please forgive my bad drawing because this is only I can draw. So this is uterus. What we have to do is, we have to do laparoscopic cholecystectomy. Okay, because the uterine size is less. So what we will do, because at all times we have to give, there is diaphragm as well. There is going to be, the chest. There is going to be physiological changes of pregnancies as well. So because the uterine size is less, so yes, from 10 to 22 weeks of gestation, you may think of laparoscopic cholecystectomy. Okay. So you have admitted this woman, and if you think that she is 10 to 22 weeks of gestation, you will do this laparoscopic cholecystectomy there and then. You will think of. But if there is advanced gestational age, Oliza, so my question to you is, sweetheart, so do you think that you can go for laparoscopy? It's going to be very challenging. It's going to be very challenging, okay? Because uterine size is high, there is going to be a lot of the physiological problems. So yes, I mean, it's going to be very challenging, even if you think of. Okay, so yes, the good answer and the wise answer is going to be no. Okay, we shouldn't be choosing that, the first line, so what we will do in that case, we will do just conservative management. Okay, we will just offer, the good analgesic, we will monitor, we will give Vte Prophylaxis, we will keep the patient admitted until she is okay, until she is, about to go home and everything. Yes, anything, Noreen, anything can happen, isn't it? So yes, that is the, the index, I think, your question. I hope it is clear to you. Lisa, is it clear to you now? Okay, sweetheart. Very good. Yes, Lina. For TOG articles, I must say, because take TOG articles as a story. Okay, so just take TOG article as a story that, okay, if this woman is coming with this is having this is having this. So what we are going to have in examination, in terms of investigation, in terms of management, and this and that. For the percentages, I must say that, in the recent, I think 3 or 4 exams, I don't see a lot of percentages, but back in 2017, 18, and even, the first exam of 19, we used to have a couple of percentages, okay? But in 2020 and even in 2021, I myself have not seen so many percentages. So in terms of percentages, I must say that, please be extremely careful with, the important percentages, incidence. For example, in terms of obstetric cholestasis, you have to have incidence, yeah? Okay, you have to have, the prevalence of anything, which is very much important, like this acute pancreatitis. This is, kind of very much important. So what is the incidence of that? 3 per 100, the 10,000, isn't it? So this should be, so this is why, we emphasize on making your own notes, handheld notes as well. So by the end of your preparation, what you will be having is that you will be having your book as well. You won't believe, I started studying for this part too. Okay, I used to make, my own notes, small notes for every topic, and alhamdulillah, till date, I do have those, the notes with me. I took those 2 small, the handbooks with me while I was traveling to UK. I have been here and there for so many other exams as well. So those 2 notebooks are like my, the partner in, every preparation there is. So I will advise all of you that even if you guys are not making, the percentage notes, or any important notes, so please do start, writing them out, because this is really going to help you. Because all you have to do is that you just have to open your, that particular notebook or anything. Okay. So you will do that. Any book? No. Part 3 I have played in 2019. Part 1 I have played in 2018. Okay. No book, no theory book. Okay, Marina, no theory book. All you have to do is you have to cram up all guidelines. Okay, how many times MCQ books to do? It all depends upon how many times you can revise. Okay, I don't say that you have to do sometimes. Okay, I will again say that you have to be thorough in your study. That whenever a question comes, so you shouldn't be very much surprised that that from where this question is coming from. Okay, so your concept, that's why my the opening statement for this session was that your concept should be crystal clear. Okay, best EMQ source, we have got couple of the EMQ books, Mahvesh. So we have got just Kunje book, Andrew Sizer. So I will I myself prefer in this order. Andrew is my all-time favorite book, then new book Justin Kunje. Okay, then we have got this Get Through book. Although be extremely careful with this Get Through book, because sometimes the keys are like kind of confusing. I must say, for every book there is, all you have to do is that you have to follow the quality questions, not quality answers. Okay, so if the quality questions are there, if you are thorough in your study, what you can do is that you can always think of, you can always discuss. So that is the beauty of group study. That is the beauty of if you guys are studying with your study buddies. So you can always think of, like, if I'm studying with Mahvesh, so obviously I'm going to ask her, so Mahvesh, do you think that this is a good, the perfect answer? So she will definitely say, oh, I don't know, I'm also like confused, so let me open this guideline. So I will open another source for this. And for example, if you don't find any question out of the guideline or any TOG article, so open strategy. I will again say e-learning. Okay, open e-learning, take access, take subscription of e-learning. don't emphasize on, the things which are circulating here and there. All right, because these are going to be, the authentic source for us. Don't look for, here and there or anything. If you still don't find anything, so you can always seek help from mentors. Okay, you can always seek help from, your seniors as well. I'm sure, there is plenty of help available. Okay. Yes, we have been doing, we have been doing TOG articles in mini schedules as well. So inshallah, we will do more. Okay, don't worry, Ishil. Okay. So in our course, I think we were covering all these TOG articles along with modules. Okay, so along with modules. Yes, yes. I will share, the TOG articles list, what are must to do, 3 to 5 years, I must say, because the trend has been changed in the recent 2 years. Okay, since this has been an online exam, so now they are more focusing on TOGs as well. So it's better to cover. It's better to cover. So I must say it's better not to leave any loophole. Rather, just focus. You have to be a very the focused in your what you have to do, what you are going to do, and how you are going to do. All right. Adrenal insufficiency. Yes, that is very important. So I will try to summarize that in next. Okay, I will take another session after like I must say 2 weeks. Okay, I will do this adrenal for you. Okay, don't worry. All right, guys. Thank you so much for your patience. Thank you so much for being here.